Hello everyone, and welcome back to our clinical psychopharmacology series. I'm Dr. Ben Osevwe, DNP-PMHNP-BC, and today we are diving deep into a medication you will see daily in clinical practice. We are talking about Aripriprazole, widely known by the brand name Abilify. This isn't just another antipsychotic. It represents a unique class that every PMHNP student must master for the boards and for patient care. Before we unpack the pharmacodynamics, a quick reminder. This content is for educational and board preparation purposes only. Always refer to the latest clinical guidelines and prescribing information. What makes Aripriprazole stand out? Unlike traditional first and second generation antipsychotics that primarily act as dopamine blockers, Aripriprazole is a dopamine system stabilizer. It is a partial agonist. This is a critical concept. It means it doesn't just turn the dopamine switch off, it adjusts it to a more balanced level. Think of your dopamine system like the temperature in a room. Traditional antipsychotics are like an air conditioner that only knows how to freeze the room. Aripriprazole is the smart thermostat. If the dopamine temperature is too high, as we see in the mesolimbic pathway during psychosis, Aripriprazole turns it down. But if it's too low, it can actually provide some support. Board exam pearl number 1. Aripriprazole is classified as a second generation or atypical antipsychotic, but its unique mechanism makes it a third generation pioneer in the minds of many clinicians. Let's get technical with the pharmacodynamics. To understand Abilify, you have to look at its receptor binding profile. This is high yield for your ANCC and AANP exams. First, it is a partial agonist at the dopamine D2 receptor. It has high affinity, meaning it binds strongly, but it only has moderate intrinsic activity, about 25 to 30% of dopamine itself. In the mesolimbic pathway, where dopamine is overactive, Aripriprazole competes with endogenous dopamine, effectively lowering the overall signal and reducing positive symptoms like hallucinations. Conversely, in the mesocortical pathway, where dopamine might be too low, its partial agonism may help improve negative symptoms and cognitive function, though clinical results can vary. Moving to serotonin, it's also a partial agonist at the 5-HT1A receptor. This is the same receptor targeted by buspirone, contributing to its antidepressant and anxiolytic properties. It acts as an antagonist at the 5-HT2A receptor. This antagonism is a hallmark of atypical antipsychotics, helping to reduce extrapyramidal side effects and potentially improving mood. Board exam, pearl number 2. Know the triple threat. D2, partial agonist, 5-HT1A, partial agonist, and 5-HT2A antagonist. This combination defines its clinical profile. Now, what do we use it for? Aripriprazole has a broad range of FDA-approved indications that you need to be familiar with for clinical rotations. It is a first-line option for schizophrenia in both adults and adolescents. Its favorable metabolic profile often makes it a preferred choice for younger patients. In bipolar I disorder, it's used for acute mania and mixed episodes, as well as for maintenance treatment to prevent future mood episodes. One of its most common uses is as an adjunct treatment for major depressive disorder when SSRIs or SNRIs alone aren't providing full remission. We also see it prescribed for irritability associated with autistic disorder in children and for the treatment of motor and phonic tics in Tourette disorder. Dosing Aripriprazole is an art and a science. It's not one size fits all. The starting low and going slow mantra definitely applies here, especially for certain populations. For depression augmentation, we start very low, usually 2 to 5 milligrams once daily. We are looking for that nudge to the dopamine system without causing overstimulation. For schizophrenia or bipolar mania, the starting dose is typically higher, around 10 to 15 milligrams. The target therapeutic range is often between 15 and 30 milligrams per day. Board exam Pearl 3. The maximum daily dose is 30 milligrams. In practice, doses above 15 milligrams often don't provide more benefit, but significantly increase the risk of side effects. Don't forget metabolism. It's processed by the liver via CYP, 3A4 and CYP, 2D6. If your patient is a poor metabolizer of 2D6, you may need to adjust the dose downward. While aripiprazole is generally well tolerated, it has specific side effects that we must monitor closely to ensure patient adherence and safety. The big one with Abilify is akathisia. This isn't just feeling a little nervous. It is an intense internal sense of restlessness, the need to move that can be distressing. If a patient reports akathisia, we can consider a dose reduction or adding a medication like propranolol. It's often dose-dependent and usually appears early in treatment. Metabolically, aripiprazole is one of the cleaner atypicals. It has a low risk for significant weight gain, dyslipidemia, or diabetes compared to medications like clozapine or olanzapine. It also has a low risk for prolactin elevation. In fact, because it's a partial agonist, it can sometimes even lower prolactin levels that were raised by other antipsychotics. Here is a unique warning: impulse control problems. The FDA added a warning about compulsive gambling, binge eating, shopping, and even hypersexuality. This is rare but real. Always ask your patients if they've noticed a sudden increase in these behaviors since starting the medication. It usually resolves once the medication is discontinued. Now for the serious stuff. All atypicals, including aripiprazole, carry a black box warning: an increased risk of death in elderly patients with dementia-related psychosis. When used for depression, we must monitor for increased suicidal thoughts and behaviors, especially in children, adolescents, and young adults under the age of 24. While the risk is lower, always watch for extrapyramidal symptoms, tardive dyskinesia, and the rare but life-threatening neuroleptic malignant syndrome, or NMS. Let's look at a case study. Imagine a 32-year-old male with schizophrenia who has struggled with weight gain on other medications. Why might aripiprazole be the right choice? We choose it for its weight-neutral profile and low sedation, helping him stay active. But after 2 weeks, he starts pacing and can't sit through a movie. What do? That pacing is a classic sign of akathisia. We recognize it, explain it to the patient to reduce his anxiety, and adjust the dose or add a beta blocker. That is PMHNP management in action. Board exam Pearl 4. Diagnostic distinction. Akathisia is a movement disorder, not increased anxiety. Don't mistake the physical urge to move for a worsening psychiatric state. Family education is paramount. Caregivers are our eyes and ears in the home setting. They need to know what normal side effects look like versus red flags. Explain that mild nausea or insomnia might happen early on, but often fades. But emphasize that any unusual movements or sudden changes in mood must be reported immediately. Ready for a practice question? Which of the following best describes the action of aripiprazole at the D2 receptor? Is it an antagonist, a full agonist, or a partial agonist? The answer is partial agonist. This is the stabilizing effect that allows it to modulate dopamine rather than just shutting it down. Get this right, and you're well on your way. Briefly, for board prep, remember that aripiprazole also comes in long-acting injectable forms like Abilify Maintina and Aristada. These are vital for patients struggling with adherence. Board exam Pearl 5. When starting a long-acting injectable, an oral overlap period of 14 to 21 days is typically required to ensure therapeutic levels are reached. Check the specific brand's protocol. Even with its lower risk, PMHNP best practice dictates regular metabolic monitoring. Baseline BMI, waist circumference, fasting lipids, and A1C should be checked and followed. Let's summarize the key teaching points. Aripriprazole's triple mechanism, D2 and 5-HT1A partial agonism plus 5-HT2A antagonism, makes it a unique system stabilizer. It is versatile with indications ranging from schizophrenia and bipolar mania to adjunctive treatment for depression and pediatric irritability and autism. Dosing starts low for depression, around 2 to 5 milligrams, and higher for severe mental illness, typically 10 to 15 milligrams, with a hard ceiling at 30 milligrams daily. Your clinical priority is monitoring for akathisia, screening for new impulse control behaviors, and being mindful of the dementia-related black box warning for elderly patients. As a PMHNP, your role is to provide precision in medication management and empathy in patient care. Aripriprazole is a powerful tool when used with this balanced approach. Thank you for joining me for this deep dive into Aripriprazole. Mastering these details is what separates a good student from a great clinician ready for the boards. I'm Dr. Ben Osevwe. We are here to support your journey from student to practitioner. If you found this helpful, please subscribe and share it with your cohort. For clinical support or mentorship questions, you can always text us at 832-991-6516. We are here to help you succeed. Don't forget to join our mentorship family today at rotationmatchnetwork.com. Let's build the future of psychiatric nursing together. See you in the next video.